Good evening, everyone. This is FAFP Executive Vice President Jay Milson, and welcome once again to the FAFP's COVID-19 webinar series designed to assist Florida's family physicians and their staff in dealing with the ongoing corona pandemic. Tonight, we welcome back one of our very own rock stars, FAFP past president and former AAFP board member, Dr. Bob Raspa, who's going to introduce our speaker this evening. Dr. Raspa?
Thank you, Jay. And I did want to be a rock star, but I quickly learned I needed a backup plan, hence medicine. But that's a story for another day. Tonight, I want to introduce someone who I not only earned a great deal of respect for during my tenure on the AAFP Board of Directors, but an individual I'm humbled to call my friend, Mr. Shawn Martin. He's currently the AAFP's Senior Vice President, Advocacy, Practice Advancement, and Policy. Truly the most important division at the Academy. It's involved in practice, payment, and politics. And that's the real reason for AAFP's existence. He's responsible for overseeing the AAFP's Division of Government Relations and the Robert Graham Center for Policy Studies in Family Medicine and Primary Care in Washington, D.C., as well as the Division of Practice Advancement. His expertise in public policy is quite remarkable, and he's extremely well respected by legislatures and regulators alike within the Beltway. So much so, he's been named by thehill.com as one of the top 10 healthcare lobbyists in Washington, D.C. This respect is clearly shared within our family circle of family medicine, as evidenced by the fact that on August the 1st, 2020, Shawn will become the Executive Vice President and CEO of the AAFP, succeeding Dr. Doug Henley. Now we've asked Shawn to present on topics of national importance to family medicine as it relates to COVID-19, as well as to share perspectives of what the future holds for FAFP and AAFP members in the months and years to come. While all participants are in listen-only mode, please type any questions you have into the chat box, and Shawn will attempt to answer it throughout the program or during the question and answer period at the end. Shawn, welcome.
Bob, thank you so much. It's good to connect with you again. And Jay and Chris, thank you for the invitation to join the Florida Academy this evening. Look forward to sharing a little bit of information with you on the work we're doing with respect to the coronavirus. And as Bob said, really kind of helping you picture the direction we're going with respect to many public policy issues. So if it's okay, we'll just get started. There we go. So most of you have seen this map and this dashboard in some form or another, either on your television set or your local newspaper. And of course, this dashboard is not up to date from the time that I captured it this morning. But I wanted to go ahead and include it in the presentation tonight just to kind of level set or frame our conversation around just really the depth and scope of the COVID pandemic around the world. Certainly here in the United States, we've now exceeded 1 million cases. We're upwards of 62,000 deaths in response as a result of the virus. And we continue to see spread across the country, really without discrimination against geography moving forward. Although there are places where the curve is definitely being flattened, you're starting to see improvement in some communities. But as quickly as you see one community improve their situation, there's another hotspot that pops up. I think this is a trend we're going to continue to see over the course of the next several weeks, but certainly we're optimistic that the number of deaths seems to be slowing down from its peak towards the end of March and the 1st of April. So the next slide. When the outbreak broke in late February, early March, well before the WHO declared it an international pandemic, the AAFP really kind of set out on these 4 pillars of advocacy efforts that we put in motion. The first one we continue today, which is this issue of the supply chain and distribution of personal protective equipment, testing, distribution of information and supplies to primary care practices of all shapes and sizes. And one of the things when the pandemic is over, certainly our supply chain and distribution networks are going to be an area that get a tremendous amount of scrutiny, appropriately so. Most of the big GPOs and vendors in the country are designed to sell to large hospitals and health systems. Very few of them were equipped or even knew how to begin to distribute personal protective equipment to the ambulatory physician network. That continues today. It's a major failing of our healthcare system that needs to be addressed, but it's our understanding based upon our weekly survey that the distribution of PPE is starting to improve in major parts of the country. Now we're dealing with the distribution of tests, particularly point of care testing as that comes online, making sure that that gets to physician offices. The two bottom boxes, the telehealth and virtual care and audio only visits, as our members began to shift their workflows from face-to-face or in-person or office-based visits, it's really a remarkable story of family medicine. We went from predominantly office-based the first week of March to by the third week of March, our surveys were telling us that about 80% of family physicians were doing a majority of their work in a telehealth or virtual health platform. And that's a really remarkable turn or shift in workflow. Now, granted, the government eased a lot of regulations and made it easier for people to use technologies such as FaceTime and Skype and other types of platforms that weren't traditional telehealth platforms. And then they also, at the 1st of April, began to pay for telephone-only visits, which really accelerated the kind of asynchronous communication with patients. And then finally, the upper right box, the direct financial assistance to family physicians. This was, is and remains a major priority for the Academy. We've had a couple of programs rolled out that have provided some interim low-dollar financial assistance to practice, nowhere near adequate, and we continue to work on that, and I'll talk a little bit about that moving forward. Jay, next slide. So a little bit about telehealth and virtual care. I just talked a little bit about the telephone visits and then the telehealth payment parity, which I know largely depends upon your panel of insurers that you're contracted with. But let me spend a few minutes talking about telephone visits. So when the pandemic kind of hit and we got to the middle of March or the last week of March, and a number of family physicians had incorporated telehealth or virtual health platforms into their practice, there still was just this need to pay for telephone only or audio only visits with patients. And the primary reason was a number of patients, particularly those at lower end of the socioeconomic spectrum, and then also a lot of elderly Medicare patients just simply didn't have smartphone technology or the ability to participate in a true telemedicine visit that included both audio and video technologies. But they did have a phone. It's estimated like 95% of the US population has a cell phone. So the AAFP, along with others, went to CMS in a pretty frantic manner and said, look, you have to pay for telephone only consultations and visits. And there's these three codes that have existed in Medicare for a long, long time. You guys are probably more familiar than I with them, but 99441 through 443. And they've been services that have been inside the CPT codes for a long time, but they had never been approved as an allowable service under Medicare. So we advocated that CMS just activate those codes, which they did the first week of April. And that was a significant shift in how physicians went about interacting with their patients, particularly those that didn't have technology. I do want to report I have some news tonight. Good news is that CMS today announced that they're increasing the payment rate for those three telephone visits to $41 on the lowest end, up to $110 on the high end. So if you think about that compared to $99 to your existing patient or new patient visits, that's really upping those codes to a $99,212 up through about a $213 payment level, which provides some parity to the overall E&M codes. And this is a welcome relief. Again, we've been pressing CMS to do this for a number of weeks, and this will continue to help our practices that are trying to provide care to their patients, but also with the revenue flow issues that they face. On the telehealth side, it's been a little more complicated. Obviously, Medicare and some Medicaid programs took aggressive steps to reduce regulations and kind of basically create a free flow use of telehealth or telemedicine platforms. Many of the commercial insurers followed suit, but not all of them. We know that a number of self-insured or the so-called ERISA plans have not all covered telemedicine services. We know there's a inconsistent application of the cost sharing arrangements, whether they are charging cost sharing to the patients or they're not charging cost sharing. But I think the thing we've been focusing our attention on is creating a consistency in language and in the coding language. So when you code, we know a number of commercial insurers are asking for different types of modifiers or point of service codes, and others are not being consistent with that. So we're just asking everybody to follow the Medicare example on the CPT or coding side. So next slide. So practice sustainability, I talked about was a major priority from day one for us, and it continues to be a place where we are focusing a tremendous amount of attention. And these are the 4 economic programs that are in place. The Paycheck Protection Program is the big small business loan program that now is on its 2nd application period. We do know that some family physicians secured loans through the Paycheck Protection Program, but we know a lot didn't. And that program, if you've followed the news, is facing a great deal of scrutiny, particularly on the first tranche of money. We're hoping they improve that moving forward. We are now actually asking Congress in the 3rd version or the 3rd funding of the Paycheck Protection Program to carve out a certain amount of dollars for community-based physician practices to guarantee that it will be available to physicians who so desire to secure one of those loans. As bad as the rollout was of the Paycheck Protection Program, it pales in comparison to the Economic Injury Disaster Loan Program, which is only the $10,000 short-term loans that people in high capacity COVID areas can apply for. There was a great deal of concern because over the course of the first week, there were no EIDL loans that were actually issued in any of the areas, including New York and New Jersey, Connecticut. So there was a lot of problems with that program, and to be honest with you, I'm not sure that they've really rectified those issues. I'm going to skip the Public Health Fund and go down to the Advanced and Accelerated Payments. This is the program where CMS rolled out where you can voluntarily request a prospective payment based upon your 2019 Medicare billings. We, again, strongly advocated CMS to do this. We actually helped create the language that they use to implement this program. Abruptly, last Sunday, they ended this program. We're trying to investigate why. We know the repayment and the interest on the back end of this is problematic, but we still think it's the fastest way to distribute money to physicians for practice sustainability purposes. And then the bucket I skipped over is the public health. It's often called the Provider Relief Fund. This is just straight cash contributions. Many physicians across the country, including probably many of you on the phone, woke up one morning to a deposit in your practice account that came from United, which probably caught people by surprise, but this is just a financial contribution to help physicians and hospitals and others that have been impacted. There's the next round of money is supposed to start rolling out this weekend. And then the 3rd round will follow about a week to 10 days after that. So next slide. I see what are the assigned work RVU values to the telephone codes. I am not a CPT expert, but I believe these are just flat service codes that don't. I think they're just paid at a service rate, and they're not subject to the three gypsies. But I'm not positive on that. But I can ask our CPT team and follow up with you. But I think my understanding is the values may be national on the 99441 through 443. But it's a good question, and I'll follow up on that. So the economic impact on this slide, if anybody saw the USA Today a couple of weeks ago, you probably saw this giant front page story about the impact of healthcare or the COVID crisis on healthcare, and these two pretty startling maps. This is research that Health Landscape at the Academy did. If you look at the top map, that's kind of status quo at the end of March, and the bottom one is using a 3% attrition model to look at what the country could look like by the end of June. It is startling. The maps are meant to be startling, but a 3% attrition model is probably pretty aggressive over a 3-month time period, but it's not really that unreasonable given the financial situation facing many physician practices across the country. I also would remind you that we did this attrition model before any of the financial assistance programs were rolling out. So it doesn't take into account any cash flow and how that would prolong or impact the physician workforce. So next slide, please. So these are kind of the 4-step approaches to practice sustainability that we're really talking with our members about. Obviously, the workflow issue was organic on the ground. People had to adjust according to the needs of their communities and patient panels and practice capabilities. And we had a lot of advice about how to, help your practice kind of imagine workflow, how to change your patient appointments to bring in people that you thought were potentially infected with the COVID virus at different times, parking lot testing, all that kind of stuff. Cash flow is the place where I think we've had the most inquiries from our members into the Academy has really been about cash flow. How do I, maintain cash flow using the available programs? Why aren't the commercial insurers providing prospective payments? Can I get payment parity for telehealth compared to, in-person evaluation and management visits? All good questions, but all of them are pointing to this cash flow management issue that changed overnight for all of our physician members. Just had an immediate change in cash flow as a result of the stay-at-home orders and public health mitigation strategies. So now we're still spending a lot of time on cash flow, but we're really thinking about these two green buckets. One is kind of financial stability and the recoupment of lost revenue. So how do we maintain some financial stability of practices? And we think a big part of that is helping practices recoup this lost revenue. And this is when I talked about the public health or provider relief fund, just pushing cash out into practices so that they have both cash flow in the short term, but also just kind of an offset for all the revenue that was lost because of the decrease in patient visits. And I will tell you, I said earlier, we monitor a weekly survey, and we know that over 85% of family medicine practices saw a greater than 50% reduction in volume. That is essentially almost a stoppage of the delivery of primary care across the country as we formerly know it. Next slide. So this is kind of a screen capture. I just wanted to circle this, and I apologize it's not better focused, but this is a loan calculator that we created for members, and it's in front of our firewall, so you can share it with your office staff and non-family physician colleagues in your practices. But all this does is just allow you to input numbers from your practice, so your revenue from various payers, your overhead, your salaries and benefits, and it will help you do some revenue cycle management, so at least you can determine how much revenue you need to create based upon whatever overhead or expenses that you anticipate for a period of time. It's a little involved, I won't lie, but we tried to make it simple so that it will do the calculations regardless of how many fields you fill in. So you can fill in what you know and kind of get a snapshot to the best of your ability to at least provide you some information moving forward. So next slide. So now we're kind of entering phase 2 of our advocacy efforts, and it may seem odd to some that we're moving beyond kind of these phase 1 sustainability and PPE and personal protection issues, but we feel it's important to really start to think about what's on the other side of the pandemic and on the other side of the crisis. And some of you have probably heard of this as the primary care Marshal Plan. Other of you have probably heard the phrase primary care vision. Some of you have probably heard primary care 2025. All of these, I will tell you, are the same thing. It just depends upon who is promoting them. But I summarized it this way in a recent blog posting about the ability of the discipline to capture the lessons learned and the opportunities presented by the crisis. So there's a number of things that happened and that are becoming apparent in the crisis. I talked about the supply chain and distribution network, but another one was the kind of robust flexibility of the family physician workforce to adapt and continue to provide care under difficult circumstances and changes in environment and disruption of workflows. But the value of family medicine, both for those that were impacted by the pandemic and those that just had ongoing healthcare needs, was really amplified during this time period and continues to be today. And I framed it up this way about just needing a plan that is just kind of bold enough to create fundamental change and have enough impact or disruption that future generations will notice that something happened. And all I was really trying to say in that statement is this can't be incremental change. I think we have to use this opportunity to create a significant demonstrable change in how we approach and pay for primary care in this country. So next slide. So this is a little bit, about what we're talking about, and you're going to see all kinds of different versions of this. There was a Health Affairs article last week. There was a Washington Post op-ed from some primary care physicians in, Massachusetts on Sunday. You see lots of people writing about this, but this is kind of the core element. And I always talk about getting rid of fee-for-service, but I want to add a disclaimer that I don't think fee-for-service ever goes away entirely. There will always be a fee-for-service component in family medicine because some of you do OB, some of you do in-office procedures, some of you do sports medicine or other types of things. Some of you do, manipulation and manual medicine and other types of things. So there will always be a fee-for-service component, but what we're talking about is the core payment element of fee-for-service being incongruent with the core longitudinal and comprehensive goals of family medicine and primary care. And I continue to suggest to the world and to policymakers that the RBRVS system is the opposite of what primary care is. And primary care is continuous and holistic and portable. And the RBRVS is units of care, units of time, and sites of service. It's just very rigid on units. And those two things ultimately just don't contribute to the success of each other. And I think what happened over the course of March and April just brought to the forefront just how incongruent those two things are to each other. And I think we as a discipline and certainly us as the academy need to be bold about our vision of a better way to pay for primary care in the future. Next slide, please. So these are some resources, and some of these things are articulated on here. If you haven't used this website, it's really good. There is far more information on here than you can navigate on any single day. But that giant little search box up there at the top will help you kind of get to what you're after. Our team, in collaboration with the Florida Academy and other academies, have been just really compiling as much information as we possibly can, distilling it down to the core elements that we think members need and putting it on our various websites and making it available to you. So I encourage you to use it. I promise you, if you email me that there's something you need that you don't see on one of these websites, we'll figure out a way to make that available to you moving forward. Next slide, please. So the next steps, Bob was very kind in his very thoughtful introduction of me tonight to mention that I will be taking some next steps in the course of the next few weeks. On June 1, I will transition into a new role with the Academy as the CEO designee, and then we'll assume responsibilities for the position on August 1st, replacing Doug Henley, one of the more consequential leaders of American organized medicine, and certainly my career and lifetime. And as I said to our board, I'm really humbled by this opportunity, and look forward to working with members across the country, working with Jay and Mark and the other chapters, and really creating a better future for family medicine and primary care. And I always refer to this as our future. I think for so long, we've had a tendency to want to respond to how other people want to shape family medicine. And it is going to be my approach to this position that we're going to be the authors of our own future. So that will be my approach every day. So there's a few questions I would like to get to. Some were provided to me in advance with respect to, one of the questions was about the high number of now unemployed or people that have lost health insurance because change in employment status, and how is the Academy approaching that, with respect to marketplaces and Medicaid. So I think it's a really good question. It's something that I think is kind of lost in the national narrative at the present time. People are rightfully focused on the virus and the treatment and cures and surge and hospital capacities and the mortality rate, but there is this kind of underlying hit that our healthcare system is taking as people lose health insurance. And data and research from around the world for multiple decades has shown that people with continuous healthcare coverage and access to primary care have better health outcomes than those that lack both or one. So I think we as a discipline and as organizations need to be concerned about the growing number of uninsured in the country. I think there's a few policy solutions. Certainly, if you're in a Medicaid expansion state, that's one pathway that is going to help as people lose their employment and lose their employer-sponsored health care if they are eligible to get through Medicaid expansion. That's one pathway. The other one is certainly the marketplaces provide an opportunity. I think we're a little concerned at the AAFP about the emphasis on COBRA, not because COBRA is not a good short-term solution for some people that have lost coverage, but it's a very high dollar solution. And I think many of the people that are losing their jobs in this, at least to date, probably aren't financially in a situation for COBRA to be a long-term solution for them. So I think COBRA being the only option available to certain populations that are becoming uninsured right now is probably not the best solution for them or for our overall goals, healthcare goals. So I don't know if that answers the question. I think these are state and local, issues on how the states are going to help with a large number of uninsured. But from a national perspective, I think certainly continuing to impress upon states that haven't expanded Medicaid, just the true value of having that safety net available to people, and then creating robust commercial healthcare exchanges so that people can buy on the individual market at a more competitive price. So the next question is about if claims for Medicare phone visits have been held. Will the new amount be retroactive to a certain date? Great question. I didn't hit it. It's retroactive to March 1st. So any phone visits that are being held or haven't been submitted, and they should go back and reconcile the ones that have been submitted back to March 1st. So that's a big plus from CMS today. The next question is about student loans and loan forgiveness and financial response. So there's a big conversation, certainly in the medical education community and amongst students and residents, about two things. One is kind of loan forgiveness, which I'll address here a little bit, and the other one has been coined hazard pay, which is probably an appropriate term. But a number of residents and medical students have been pushed to the front lines of care in many hospitals and communities across the country as a result of the crisis. And there's a growing movement about paying them The last number I heard was $25,000, I think, to each, resident medical student that was thrust to the front line to provide service to their communities or hospitals, just a hazard pay amount. And I think, we continue to kind of look at this across the country, and we'll be very active in determining, how they define what is considered a surge area, so that we don't have physicians that we believe should be eligible for this that would be otherwise disqualified because of a poor definition of eligibility. On the student loan front, this is a priority issue for the Academy even before the pandemic. I think we have been painting a picture about providing financial assistance to family physicians on both sides of the tax ledger is how we talk about it. So, you have your salary and how can we help supplement revenue flow and salaries and income, but you also have expenses. And one of the places where the government can, help make each dollar of salary go further is by reducing expenses. And certainly for a large number of physicians, the major expense is student loan debt. And, we're approaching three things. One is, as simple as just give every physician some type of above the line deduction for student loan debt. And that would be, a year away, but it would impact, physicians at some point. The other one is just a blanket reduction amount in debt. So the government would just pay off, some dollar amount of debt for every physician, probably only on the public loan side, but that's another one, just another direct cash outlay. And then the third thing that we've been exploring is there is the ability under current tax code for certain individuals to deduct the amount of the interest paid on an annual basis. That policy is called student loan interest deduction, SLID. It has upper income thresholds that largely disqualify any physician from ever participating, even during residency. And we've been really advocating to raise for a 3 to 5 year time period the upper income thresholds of the SLID deduction, so that more physicians could qualify for that. And it's not a huge amount of money on the tax deduction, but if you think about the amount of interest you pay, every year, 12, 15,000, probably maybe a little more, it would have some impact and would help physicians. Let me see if I got all the questions here, Jay.
Yeah, you have one from Dr. Saber at the top.
The first one, here we go. Unintended consequences of staying at home, have people, ignoring symptoms and not seeking care, or being discouraged from in-person care at the physician's offices. The question, I think, is about postponing, the call to postpone routine care or non-urgent matters and using telehealth, but how do we begin to kind of ease those in the use of when you need a physical exam. So and PPE, let me kind of take this, I'll use a narrative form to answer this. So there was a push in the AAFP actually put out a policy about non-urgent or non-essential care and encouraging not only, the public more broadly to adhere to public health mitigation strategies, but also for family physicians to encourage people to adhere to those mitigation strategies through their workflows. And, it did create some, challenges. There's probably a lot of pent up demand because, as you guys know, there's 6 in 10 Americans have a chronic condition, 4 in 10 have 2 or more. There's 330 million people out there with healthcare needs that are unrelated to COVID. A lot of them have been engaging on telemedicine, but an overwhelming majority of them have not. And how do we start to re-engage with people that have ongoing healthcare needs moving forward? There are places where this is really urgent. Dr. Saver talks a lot about people that have multiple chronic conditions and need to be seen, and a telehealth visit isn't suitable to the exam and engagement with that patient for their healthcare needs. And I think we're reaching a point where we have to start bringing people back into the office. Another place where this is really playing out is on the vaccination side. There's been a number of articles and studies that are showing a really dramatic and deeply concerning reduction in the number of children that are being vaccinated. You know, the AAFP and the American Academy of Pediatrics have been kind of, you know, ringing siren bells about the fact that we could have another pandemic from preventable diseases because we're not vaccinating large numbers of children right now, and especially if we go back to school without a lot of people being vaccinated prior to that time. So Dr. Saver asked a number of good questions about opening the office and how do you change workflows to accommodate this, and the amount of PPE that you need for both patients and to protect your staff. And all of these, you know, are local decisions. I think some of the best ideas I've heard have been really focused on, you know, workflow management and, you know, having health maintenance or health checkups in the mornings, and people with upper respiratory symptoms, you know, come in the afternoon. Some practices we've heard are doing, you know, pregnant women and children on Tuesdays and Thursdays. And I think there's a lot of creativity out there and that can be shared through peer-to-peer learning. And I know you guys have platforms within the Florida Academy to engage in that, but I would, not being a physician, not participating in kind of the clinical setting, I would encourage a high degree of peer-to-peer learning here to kind of think about how people are doing it, what are the best practices. But we get a lot of examples that come into us on workflow management of really separating people with upper respiratory symptoms from the rest of your patient population, and just having them come in at certain times, screening them in the parking lot, you know, making sure they don't touch door handles and they're not sitting in your waiting room and things like that. But it's a really good question. I'm sorry I can't provide a better answer to that. I will tell you that I think within the next 3 to 4 days, the AAFP will be putting out some guidance on what we're calling expanding office operations. So I think, you know, our clinical experts will have a little more background on this coming pretty soon.
Yes, so Shawn, I'll follow up on that. This is Jay. And so what do you see the new normal for virtual visits being? I mean, I can make a two-part question too, which we laughed about before the end of the call, but I'll get to that later. But so you've got insurance paying parity now, and they've been very accommodating, let's just say. And we look to Medicare as that standard, and most have followed. What do you see moving forward? Is this going to move the needle enough to where we would expect the insurers to continue to, if not stay at parity, but increase, you know, reimbursement to do what you just said? So, you know, in essence, if you don't need to come into the office, let's not have people come to the office, you know, notwithstanding.
Yeah, I think there's a couple things here. It's a really good question, and I've been doing a lot of thinking around this. So I think we accelerated by about a decade the adoption of telemedicine as a result of the COVID pandemic. I think, you know, what would have taken just a number of years and relaxed regulations, payment parity, just all happened in a matter of weeks because of the pandemic. So I don't think we will go back to 2019 coverage and payment policies with respect to telehealth. But I do think there will be a right sizing. And I think, you know, patients and their physicians will create a, you know, environment that kind of right sizes the use of telehealth. And a lot of it will be driven by payment models. If we were in a kind of prospective or global payment model where the modality of care or site of service was, you know, the payment was agnostic to site of service, if you will, I think you would see an even greater acceleration of telemedicine into the future. I think if we don't get to those global payment models, I still think you will see an acceleration of telemedicine, but I think it'll be more on balance with face-to-face visits, because there's still only certain things you can do face-to-face. And even if you have a longitudinal relationship with the patient, you still are going to need to bring them in from time to time. And what I've been saying to Congress and the administration and a lot of reporters is to think about telemedicine moving forward is the 21st century house call. So, physicians will determine how to use those kind of virtual house calls based upon their experience with the patient. And I think the arms race, if you will, is going to be, what I refer to as vendor solutions on telemedicine versus telemedicine being incorporated into a comprehensive family medicine practice. And if we move to just a vendor solution where it's, low acuity, $25 telemedicine visits, I think that would be, I just think that would be a real failure of the opportunity that we have in front of us.
Right. And I think, Dr. Raspa, did you want to add something?
I actually wanted to add to the question about PPE. I know that large systems are finding ways to recycle PPE in very interesting fashions, like using UV light to sterilize the N95 mask, making sure everyone uses the same gown to go into a room. I think there are ways that if you look at your practice and know your practice flow, on ways that you can conserve your PPE so that you're not running through PPE like crazy with every person coming in and out of a room, having to totally change everything at all times. So I think there's ways to make that happen. And of course, everybody's circumstance is unique, but maybe some brainstorming and exploring that in your own practices will save you a bunch of money and save a lot of hassle.
Yeah, excellent point. So there's two more questions. Jay, would you like me to
go ahead.
attack this? Okay. So the next question is, kind of asking about how do we use the crisis to accelerate, the future of patient care and primary care. I think this is a really great question, and certainly I think this is a place where we're putting a lot of attention, and we're going to start to put a lot of resources moving forward. I think one, I don't think the street value of primary care has been as high as it is right now in my time at the academy. I think the performance of our members in family medicine and primary care across the country has been incredible, and I think it's to be applauded. I also think it's to be celebrated, but more importantly, I think it's to be rewarded. And whether it was family physicians being redeployed, within their health system or hospital to fill in the ICU or the emergency department or OB, et cetera, it's just really provided an opportunity to show the depth and breadth of skills of family physicians. So I think there's some things that we need to do to capitalize on that. I think one, obviously, there's all the workforce issues that we need to focus on to improve the pipeline for family medicine. But I think it also is an opportunity to build out the scope of practice for family physicians and, build on the crisis to say, at this, we demonstrated the ability to perform at a high level across the healthcare system during the crisis, and we can do that every day. And I think the healthcare, system of the future, where the value that is desired from each dollar spent on healthcare being as high as it is, family medicine is uniquely positioned, and it's going to be our responsibility at the academy and working with, Jay and the other state chapter executives to capitalize on the opportunity that's in front of us with respect to family medicine. And I think it's sitting there for us, and I think there's a lot of opportunities. So I think it's a really good question, and certainly we're going to start with delivery payment, and I'm always hesitant to use scope of practice because it has a negative definition with most physicians, but scope of practice in a positive way of building out the scope of practice to full scope family medicine. And then the last question is, there's a lot of visits that can be done by other members of the team. Are people allowing these to be paid for by telehealth? And the answer is yes. Like, a lot of people are starting to allow consultations from social workers. I don't know about the dietitian question. That's I just can't answer that, but certainly the health coaches and the case managers are able to engage in care management type services via telehealth or just straight phone calls. So that is happening. I think that will be here to stay. I think when you think about concepts like the chronic care management code, which kind of opened the door to phone interactions from the health coach or care coordinators, I think you're just going to see that continue to expand.
Okay. I'm gonna circle back. As I said, it was kind of the second part of the question. So the insurers and payment for telehealth, kind of segue back to what we talked about with the Marshal plan or prospective payment. I mean, what we've been talking a lot about from the execs behind the scenes in our discussions is the insurers prospectively, or you would imagine that they're sitting on a lot of capital, a lot of cash right now, because they're not paying out claims as they have traditionally. They're not even paying them at the rates in which they are. They're not, we're not seeing, family physicians aren't seeing patients in their clinics, and no elective procedures, at least until now. Like in Florida, and Monday they're going to open up. But what do you see in your discussions with the national insurers in terms of the prospect of them doing prospective payment? Is that going to be situational by state? Are you seeing any? Are you getting any feedback as to whether or not that is a possibility within the private sector?
Well, I think just straight cash outlay prospective payments, I think you will see a couple of them do this, later this quarter or into next quarter to just provide some assistance. And there's a lot of motivation amongst the insurers to maintain a robust primary care network that's unconsolidated. I don't even know if that's a word, but they're motivated to prevent consolidation, I guess is a more eloquent way to say that.
Right.
So I think, you're going to see them more engaged in that. Where I think we're doing most of our work with them is looking towards the 2021 contract period about how, are they positioned to accelerate kind of global prospective payment models for primary care, irrespective of risk. And this is where we're really leaning on them. They've always been willing to do it with this, weird risk calculation, but are they just willing to do it as a payment policy? And I think some will say yes to that. I think we're still, a couple of months away from any type of public announcement, but I think some big national commercial insurers will say yes to just prospective payment.
Okay. I
No
think
promises.
that's wrapped. Yeah, exactly. Well, yeah, we love promises in these trying times. I did get one other question just through a text about scope of practice. I know that's your favorite subject. It's kind of a sore subject here. Still in Florida, we're still trying to figure out and regroup after our legislative session that parlayed immediately into COVID. So we really haven't unpacked that. But based upon what's happening nationally and the advice through the administration to loosen restrictions on scope of practice in states that don't have supervisory, I mean, what any thoughts on that? I mean, to elaborate any more, I mean, it's a tough proposition, obviously, for those that are still required by supervision.
It's a really interesting issue, and like you, Jay, I've spent my entire professional career, kind of in and around these debates, so it's familiar territory. I think the administration's announcement of kind of easing, previous regulations that prohibited certain clinicians or providers to do things within the Medicare and Medicaid programs. I think, we're going to be advocating that they roll those back at some point to, the previous regulatory level. I think when I don't think we should make permanent provisions that were put in place in this area in response to the crisis. And nor do I think from a matter of public policy that the things they've done to try to assist in the crisis are necessarily inappropriate in all cases. I think, it's kind of an all of the above type approach in many of these issues, but I think we should roll back to the previous regulatory level. I think the I think there's some interesting lessons that we're starting to pull out of various hotspots around the country. So we do know, like in a state like New York, they actually took a lot of their nurse practitioners out of the hospital floors and direct care and brought in physicians because they needed a different level of skills and competency to help take care of these patients. So I think, you know, those types of admissions on limited abilities are going to be things that we're going to have to better understand. And I think that applies in, you know, also in the ambulatory setting. I think there's just limits to capabilities. And now the challenge is, you know, there's tremendous value in team-based care. There's tremendous value in having an all-hands approach to the delivery of primary care. The country probably needs a robust team-based primary care network. I think, you know, every role contributes to each other, but not every role is the same. And I think we're going to have a lot of work to do moving forward, even in states where there's been expansion of scope of practice. I mean, you know, so I'm sure you're thinking this to yourself and your board is, well, now they expanded scope of practice, so now what? You know, like, what does that actually mean in practice on the ground? And the reality is, in practice on the ground, is that nurse practitioners and family physicians are going to be working in environments either in, you know, aligned team-based settings or in roles contributing to each other. And, you know, we need to find a way to make that work. But those two individuals are not interchangeable. And I think that's going to be a more public affairs than public policy moving forward.
Right. Yeah, I completely agree with you. And that kind of leads into a question that came through just real quick on controlled substances, because able to do that virtually for non-malignant chronic pain. That deadline's May 8th. And for those that whoever asked the question, I do believe that they will probably, just as Shawn said, those things will roll back to the previous policy as it were, particularly as the state opens back up. But we will be keeping the membership up to date on that as soon as we get the emergency order lifted or extended through the Surgeon General in the state. But those are all great questions. I think we're getting close to wrapping up here. I'll ask Dr. Raspin, and we did not introduce earlier, but Dr. Chris Scuderi, our COVID Task Force Chairman, is on the line as well. Did gentlemen have any other questions for Shawn before we wrap up?
Shawn, this is Chris Scuderi. Just wanted to thank you for being here tonight and for the great information for the advocacy for family physicians. You know, one of the biggest challenges, and I think we're really seeing still coming out of this, is just the work being done after hours by family physicians. And is there any push to continue to find reimbursement or value or ways to decrease this? I think, you know, during this COVID crisis, we've seen more emails from patients, and it's difficult to get the patients to agree to pay for something that they previously wouldn't. So just, is there any advice you'd have or any ways that the AAFP is looking to advocate on this behalf?
Yeah, it's a really good question. So I think one of the things we've, you know, when I talk about all the lessons that we're learning, you know, one takeaway that our team had immediately was how fast people were willing to give up quality and performance reporting mechanisms and prior authorization and utilization review and all of these things that we've just been told are, you know, imperative to the success of the healthcare program, and how fast they gave them up, you know, in the midst of the crisis. So I think we're starting to talk to them about, you know, well, there's no reason to put them back, you know, to the previous levels. Your question about email, I think this is a workflow challenge that I'm really, Chris, I would pose it, I would phrase my answer like this. Like, I think we are experiencing a disruption in workflow in primary care that probably, you know, resembles a lot of what happened in other industries about a decade ago. I think it's more of an issue to work through and determine how the payment policy incorporates those than probably stopping it. Because I think patients, I don't know about your patients, but I'm assuming, you know, that's how they communicate with everybody else in their life, and they want to communicate with their physicians using those same platforms as well. So we're capturing data that shows the increase in email and texting if you have secure texting, and you know, people working through their kind of patient portals and communications like that. But I would be really hesitant to say that's going to go away, because this may hurt your feelings, but I actually think it's going to increase. But you know, we want to take away all the other administrative functions that we think are just tremendously low value, starting with kind of, you know, the quality reporting, you know, industrial complex that's taking place, and let you communicate with your patients, and we'll create payment models that incorporate that.
Yeah.
That was probably more depressing than you wanted.
No, I think it's a fantastic way to keep patients engaged. It's just it's a lot of work, so we just have to find ways to find value in it.
Yeah, and I think I hear this a little bit in your voice. I think physicians are going to have to create boundaries. You know, there's going to have to be an expectation of, you know, when you're going to respond and the time frame with responding, and you know, I think there will be boundaries established, and everybody will accept those boundaries. But I understand your concern.
Well, I started out this presentation talking about, you know, Dr. Raspel being a rock star, but let's face it, when anyone sees their physician in the out in public, you really are considered a rock star, and it's not just because of coronavirus. I think that you're held in such a high regard that people want access to you. So I think what Shawn's saying is absolutely spot on, from a sense that you're going to have to set those boundaries, because you know, it's going to be continuously, you know, challenging, particularly as we get, you know, used to this new normal. And what that new normal is going to be defined every day as we progress through this. And so that's what our jobs are. Shawn's got the big job. I got the smaller job here in Florida, but we'll be working as closely and collaboratively together to make sure that we're helping our members, because that's what we exist for. So,
yeah.
Shawn, I think that's it. We just want to thank you so much for taking your time tonight to share all the information you did and your experiences, and we are very much looking forward to working with you in your new role as EVP of the American Academy of Family Physicians.
Well, Jay, thank you for your friendship and collaboration over all these years, and I very much look forward to continuing working with you and your members. And thank you for having me tonight, and please let me know what we can do to help.
Awesome, we certainly will. So I'd like to thank all of our participants tonight as well for joining us and all the questions. If you know, others, shoot them to us. That's once again why we exist, and we're happy to get back to you as soon as possible. On the screen, you'll see we've got our next installment, May 7th from 8 to 9 o'clock. We're going to be addressing health disparities. It's a COVID crisis. I know there was some discussion about that on the town hall last night for AAFP, and look at some specific examples here in Florida, particularly in the Jacksonville area, possibly Gainesville, Florida, and the Miami area. But we're still putting that together, but we look forward to having you next week. In the meantime, please, everyone, we once again thank you for logging in, and we hope that you will continue to do so through FAFP.org and our resource page, as well as the AAFP resource page, as Shawn had pointed out. And we just hope that you have a fantastic evening. Be well, stay healthy, and good night. Take care.
Night, everybody.